All right. Well, I feel like you guys are like the natural selection group that's made it to almost the end of the day. This is amazing that you are all still here. And I feel compelled as a physician and as an internist to ask you to make circles with your legs so that you don't get clots in your legs sitting all day. So I'm just thrilled to be here. Palliative care and providing palliative care to vulnerable patients is a real passion of mine. So I'm excited to talk with you today. I direct the palliative care service at San Francisco General, and so work with vulnerable patients every day. And I'm excited to be with a group of like-minded folks. Okay. So the things that I want to go through in a short time today is we've already talked a bunch today about what do we know about health literacy as it intersects with palliative care. I'm going to talk a little bit about advanced care planning and just kind of round out some things that we've heard about already. To ask what happens to these vulnerable patients when they're hospitalized, when they get sick suddenly, and then how do we address health literacy issues in the hospital. So this is where I work. This is San Francisco General. It's the level 1 trauma center for the county. So anyone, any kind of socioeconomic level, when they get in a serious accident, they come to us. So as a palliative care provider, I see people from the whole spectrum of our city and really the world. Some of you may remember a couple years ago, a huge airline crashed at San Francisco General or San Francisco International Airport, and a lot of those trauma victims came to us. So people from Asia. We are the safety net provider for San Francisco. We provide about 80% of the charity care in San Francisco and see a disproportionate number of uninsured and Medicaid insured patients, minimal numbers of commercially insured patients. We're the second most ethnically diverse medical center in the United States, and on any given month, 140 languages are spoken on our campus. So those are some statistics, but who are our patients? So these are not actual patients. They're examples of typical patients that we would see at San Francisco General. So on the left, this is to represent a large proportion of immigrants that we care for. So among that population of patients, I would say some commonalities would be people who may have limited English proficiency, for whom the medical system in the United States is foreign in a lot of different ways. The way that you interact with healthcare providers, the way that care is provided and compensated and all that is very different. Talking about literacy, just even the ability to read and write rates are different. And then, of course, cultural issues, which I'll talk a bit about more later. And then on the right, we see a large proportion of, I would say, socially isolated patients, large proportion who are marginally housed and homeless, many of whom struggle with mental illness, substance abuse, or both, who have limited caregiver supports, limited social supports, and continuity relationships with healthcare providers. So what do we know about advanced care planning in vulnerable patient populations? One of my colleagues who works at the San Francisco VA, Rebecca Sidori, has done a bunch of work looking at patients in our general medicine clinic. And so some of these studies are reflected here. So low health literacy is associated with less advanced directive completion. And then if you do actually complete an advanced directive, less certainty about what you've chosen for yourself. We know that particularly Latinos and Asians are less certain than whites and in choosing their wishes in advance, and that an intervention that was tried in our general medicine clinic to help improve advanced directive rates, there were actually still remaining low completion rates, which isn't surprising if you see that people are not certain about the choices that they make. They're not particularly motivated to complete an advanced directive. So I'm going to focus on the hospital because that's where I work. And I don't know about the healthcare providers in the room, but this picture, which is not from our hospital, starts to make me anxious just looking at it. I've walked into many, many rooms like this where there's a patient who's in distress, who is, as we'd say, crashing. And then there's a provider where the person who's over the rails is someone I've been in many contexts, trying to have a conversation with a complete stranger about what he or she wants in this acute situation. So this person, regardless of where this man is starting from his health literacy perspective, when you come in and you can't breathe, and you're not thinking well, you're anxious, it's really hard to process what's coming at you at 1,000,000 miles an hour. Providers are coming at you who you've never met before, who are asking questions with great urgency around what do you want us to do 5 minutes from now? And you don't really know exactly what the implications are of those choices that you're making down the road. So it's a really tough situation for anyone, but particularly those who are starting with low health literacy. So some of the hospital factors, the hospital culture, I think that we as medical providers forget how foreign this is to normal people. And you know, particularly with the patients that I'm taking care of, we bump into things all the time. Things like, you know, I work with a large Chinese American population, and I hear almost on a weekly basis, well, he's really weak because you're taking so much blood from him. You're taking blood every morning and all of these tubes of it. Of course he's weak. Or, you know, a person whose primary coping strategy is to chain smoke. And we put him in the hospital, and we put a nicotine patch on this person and say, well, that's just as good as your regular coping strategy. And then we say, oh, and by the way, you have this horrific diagnosis. And then this person says, I have to use my coping strategy of going to smoke. And we say, well, then you need to sign out against medical advice because you're not allowed to leave your room. So we bump into a lot of hospital culture factors. People in the hospital are often disconnected from primary care and other trusted providers in the community, and it's strangers who are talking to you. And then, of course, lots of communication barriers. We talked about interpreters. This is an actual sign in our hospital, which is just to the left of the check-in desk at the radiology department. And no one can read this, I'm sure, in the audience. But even if you're standing 2 feet away from it, I guarantee you can't read it. The top one is basically your right to a medical interpreter in English, Spanish, and two different forms of Chinese. So again, there are hospital factors, and then there are provider factors. So as has been mentioned already before, physicians in particular, we are very at home in medical facts. And when we get stressed out and scared about what's going on, we default into lots of medical information and jargon. And when the patients experience this, they're getting input not just from the primary treating team, but also from various consultants who may disagree on exactly what's going on. And this is incredibly confusing. As been mentioned already, we in healthcare often focus on treatment decision as opposed to values. And that's an important tenet in palliative care and something we try to do. But also, other last provider factor is that we are so comfortable as physicians being the captain of the ship in all these different medical decisions until the most difficult decisions arrive, right? And then we say, it's up to you, patient and family. It's all about autonomy. You make that decision about code status or whatever else. So this, of course, results in a lot of conflict. So from the provider perspective, looking at a patient who may have low health literacy who's facing these decisions, they may come across as quiet or disengaged, ambivalent about their choices, or they seem confused because they can't recall the information that you've dumped on them before. And they may be dragging their feet about completing an advance directive, when really it's that they're just overwhelmed. From the patient perspective, looking at the providers who are coming in, they may come across as just really impatient or pressuring about different decisions, frustrated with what's going on or how the patient is reacting, repetitive, asking the same questions again and again, or providing the same information the same way again and again, and anxious or uncomfortable because we are. So how do we address these health literacy issues in the hospital? I'm going to go through a variety of communication techniques, ways to optimize conditions, provide support for decision-making and advanced care planning, and then briefly talk about some quality improvement initiatives at San Francisco General. So I'm going to talk briefly on this because it's been highlighted a couple of times, particularly for patients with limited English proficiency. We have done a lot of work 40% of the patients we see in the palliative care service at San Francisco General have limited English proficiency. So we are best friends with our interpreters. And one thing that I've learned in particular is to focus on this concept of register of what type of words the patient is using and communicating that can kind of give you a sense of how sophisticated their vocabulary is. And I never knew to ask that until starting to work with interpreters and asking them about how this patient is communicating. We want to address the impact of culture and beliefs on decision-making and care preferences, rather than arguing with that Chinese family that says, you're taking too much blood from my son, my husband, to say, well, it doesn't matter, you know, that's not what's causing the fatigue, it's the cancer, rather than just being antagonistic about it, to empathize and validate rather than fighting about it. And to address communication barriers for when patients voice their needs. I'm focusing most in this talk on advanced care planning, but of course, symptom management is really hard. And I always think about the 95-year-old monolingual Cantonese-speaking woman who's in an isolation room at the end of the unit. What happens to her when she's short of breath or in pain? How does she communicate that? So other general communication techniques, a bunch of this has already been talked about today, and I would say is very common, or I would say duh, for people who think about health literacy, but not for physicians in general. And these is part of the DNA, I would say, of palliative care and communication techniques. I would say the two things I would highlight here under verbal communication would be a lot of what we do is actually trying to organize providers to bring together interdisciplinary meetings of the infectious disease team and the surgeons and the oncologists, and getting everyone on the same page. That might be its own meeting just in and of itself before the family meeting to get everyone on the same page. And then to offer recommendations to the patient and family based on values rather than putting the decision on their lap. Using written information, I think that I thought it was great that was brought up that not everyone is a great oral learner. And I think that surgeons actually do a much better job at this than internists of drawing pictures for people, but I think we need to do that more. Having information available in multiple languages, and then offering time to either review and or read the information for the patient. These are two examples of information resources we have that were created by Rebecca Sidore, available through the Coalition for Compassionate Care of California. There are 3 informational sheets on artificial hydration, what is a ventilator, and CPR, and available in multiple languages with pictures and colors and things that work better for people with low health literacy. So optimizing conditions, we've already heard about all the things that can happen to people with medication side effects, but particularly when people are in the hospital, there's a huge risk of people getting disoriented. So reviewing medications, helping them to have a better sense of their environment, and getting people on a day-night schedule that's more close to reality, and then minimizing interruptions and multiple talkers during family meetings. Support for decision-making, again, involving other trusted people, not just surrogates and family, but also trusted providers. It's really common for a lot of our socially marginalized patients to bring in case managers and other trusted community members. I think given how uncertain people are in our hospital, in our system, about completing advanced directives, to actually figure out whether that's something that the patient is actually interested in at all, and not to fight them on that, but to figure out ways to document their wishes, even if they never fill out an advanced directive or never have a pulse. I'll show you the California Advanced Low Literacy Advanced Healthcare Directive form, again, developed by Rebecca Sidore, and with the Institute for Healthcare Advancement as well. It's written at a 5th grade reading level, has lots of pictures and colors. So I'll finish up by just talking about a few quality improvement initiatives at San Francisco General. So a few years back, when we started our program, we noticed that the same questions kept coming up again and again after patients die in the hospital. And as you can imagine, when someone dies, it's close to you, you're emotionally overwhelmed. And what happens to you is you have all of these really thorny, complicated decisions that you have to make, and kind of logistics after someone dies. So what we did is develop a trifold brochure that someone gets immediately after someone dies. And this is available in English, Spanish, and Chinese, as well as a larger resource that really walks through all of the things that have to be done, informing various agencies, talking to insurance companies, talking to funeral homes, those sorts of things. And that was done, again, in collaboration with the Institute for Healthcare Advancement. We also had a project where we developed some cue cards for people with limited English proficiency, so they can just point at what they're feeling. Even if they can't read, they can look and say, I'm hungry, I'm thirsty, please call my family, please call the doctor. And lastly, Alicia Fernandez and I partnered with a third person to develop the interpreting and palliative care curriculum, which is a pretty comprehensive training program for professional healthcare interpreters who have to negotiate these difficult conversations between patients, families, and healthcare providers. It's available both as a in-person training or on demand for a small fee. And I'm happy to talk more about this later if anyone's interested. So lastly, this is just a summary slide of our lessons learned. This is an actual picture of the main information desk at San Francisco General. You can't even read that sign because someone's standing in front of it. So we ask a lot of our patients in navigating a healthcare system. So pacing of our information is really critical in how we share information and the patient's emotional readiness to receive it. We need to adapt our communication styles and materials and bring in allies from the patient side and from the provider side. So thank you very much.